Okay, well, it's noon, so we can go ahead and get started. So welcome everyone to the University of Washington Grand Rounds. This week we are hosting the annual Dave Park Memorial Lecture, and our speaker is Dr. Lisa Chen. And here to introduce Dr. Chen is Dr. Narita. Dr. Narita is a professor in the Division of Pulmonary, Critical Care, and Sleep Medicine. And he also directs the Public Health Seattle and King County Tuberculosis Control Program. Dr. Park, today's honoree, and Dr. Narita co-founded the Furland Northwest Tuberculosis Center based at the University of Washington. So I'll turn it over to Dr. Narita now.
Thank you, Nina. And thank you, everyone, for joining the David Park lecture today. Dr. Dave Park, our honoree, was a beloved pulmonary and critical care physician based at the Harborview Medical Center and professor of medicine at the University of Washington, who passed away in September 2016 at the age of 54 after a 6-year battle with brain cancer. He was raised in Vermont and went to medical school at the University of Vermont, where he fell in love with his future wife, Julie, who I believe is here with us today. Together, they came to Seattle for residency program. Dave in internal medicine, Julie in pediatrics. Dave was chosen to be chief resident at the Harborview Medical Center. And you can see his picture in the upper left corner back then. He then went to train in pulmonary and critical care medicine and became a faculty member in the division. Dave spoke the truth and frank language with wit and the twinkle in his eyes, as you appreciate in the middle picture. He was an invaluable mentor, colleague, and friend, and he was also loved by his patients. Dave became a renowned teacher with the teaching awards from the University of Washington and an outstanding educator award from the American Thoracic Society. Dave had a wide-ranging interest, but he had a particular interest in the areas of tuberculosis, non-TB microbacteria, and medical education. These are the themes for this annual memorial lecture, which brings me to our speaker today, Dr. Lisa Chang. Dr. Lisa Chang is a professor of medicine in the Division of Pulmonary Critical Care Medicine at the University of California, San Francisco. She is the principal investigator and medical director of the UCSF Curry International TB Center, which is a CDC-funded National Center of Excellence for TB education training. Dr. Chang is the current president-elect of the Union Against TB and Lung Disease North American Region, and was recently appointed to the Federal Advisory Council for the Elimination of TB. She considers herself as a clinician and educator for frontline providers in public health and has led international training and education initiatives. Lisa has spent much of the past 15 years as a global TB consultant for technical assistance, supporting the international drug resistance TB programs of Tanzania, Indonesia, and Uganda with the development of national guidelines, training programs, policies, and procedure. She is also the co-editor of the highly regarded resource book, the Curry Center's Drug Resistant TB Survival Guide. In addition, Dave Park, Lisa, and I worked together and led TB intensive courses in Seattle. We asked Lisa to talk about the new treatment breakthroughs today. Thank you, Lisa.
Thank you, Masa, for that kind introduction. And thank all of you for inviting me here. I'm really pleased to be with you. And I really do want to start with a tribute to Dave Park. And I know those of you in the UW community who knew him well really valued him as an outstanding educator. You know, Dave clearly was a clinician's clinician. He was a scientist, and particularly, I think many in the audience would probably include him as a great friend. He clearly had the sharpest, dare I say, devious wit, great brains, and tremendous kindness. So it's really a great honor to join you today and give this talk at this session. Disclosures, I don't have any conflicts of interest for this talk, but I will be talking about off-label use of many of our second-line drugs for TB. And I just added the rest of the disclosures from UW that they sent to me. So like the rest of you, I really have spent most of this last year, a year and a half, doing nonstop COVID work. I'm finally back. I'm honestly really relieved to be back to the TB world. But I also recognize that in this audience today, there's a healthy mix of academic internists and many specialists. And many of you, like me, do a lot of global work. And we're looking around and assessing what's the collateral damage right now from this pandemic to the diseases that we care about deeply. And I was just on a call recently with colleagues from Stop TB, and one of my colleagues said something that really resonated with me. And it was just that he was reflecting on TB as being that everlasting pandemic, but always in plain sight. TB truly feels like it's as old as mankind. You know, I think the oldest DNA remains that showed TB was a mother and infant who died 9,000 years ago from TB. So truly, it's a disease that's old as time, but more impressive, it's a disease that continues to take its toll every day. And despite the fact that we can both cure and prevent this disease, before COVID, TB has been and probably will be after COVID the leading cause of infectious deaths worldwide. So I think this just tells us we need to do a better job. We know that our drugs are hard to take. They have the potential for lots of side effects. And it's hard. It's hard for TB programs, especially in countries where TB is highly prevalent, to take on this kind of care efficiently and effectively. So the bottom line is we need to do better. And what I'm really happy to be able to share with you is some good news in terms of both drug-resistant and drug-sensitive TB. But I'm going to start with drug-resistant TB breakthroughs. I do also want to get us on board with newer definitions for drug-resistant TB. And, you know, the definition of MDR stays the same. It's resistance to both at least isoniazid and rifampin. But in this last year, both the definition for pre-XDR and XDR changed from the WHO, getting rid of the incorporation of injectable agents into our definition and replacing it with fluoroquinolone, with Bedaclin or linezolid. But all of the study data that I'm sharing with you today uses the older definition of XDR and pre-XDR. So to appreciate any newer treatment breakthroughs, I do feel like I need to walk folks through just what are we doing presently, or what have we been doing for drug-resistant TB. And I'm sharing on this slide guidelines from the US, our first national guidelines for drug-resistant TB that came out late in 2019. And basically, our recommendations are that you use at least 5 drugs in what we call the intensive phase, followed by 4 anti-TB drugs in a continuation phase, and for a duration of 15 to 21 months post-culture conversion. So we're looking for adequate response, but taking well over a year and a half to complete treatment, and then up to 2 years if you have XDR or pre-XDR. The WHO has their own guidelines, most recently updated after our US guidelines and took into account additional data. And they recommend, for those of you who work globally, 4 drugs in the intensive phase, followed by 3 drugs in a continuation phase. And they've simplified the duration to at least 18 months or at least 15 months post-culture conversion. They also include recommendations for a 9-month regimen, data supported by the STREAM trial that I'm not going to cover today. And they also had early data from BPAL, which I will cover, that they recommend under operational research conditions. So for those of you who aren't keeping track of TB care, I just wanted to share with you, and so you can appreciate the kinds of drugs that we're currently using under our current guidelines. And you can see, ATS CDC guidelines next to the WHO guidelines. And I think probably the biggest changes in the last few years have been that we rely on our later generation fluoroquinolones as our first choice, as well as Bedaclin and linezolid now as top choices to treat drug-resistant TB. We're also adding some old repurposed drugs, clofazimine, which is really hard to get unless you have an IRB, and cycloserine, which is a very old drug. And what's notable is that any additional sensitive first-line agents have been demoted in their priority of use, as well as the injectable agent, which we're so used to reaching for drug-resistant TB. A moment on Bedaclin, because this is a newer, relatively newer anti-TB drug. It was FDA approved in 2012. It's a daroquinolone, and it was the first drug with the novel mechanism of action approved for TB in over 40 years. It has excellent bactericidal activity, but probably even more important is that it has a great sterilizing activity to kill those semi-dormant organisms that make it so difficult to fully treat TB. Now, Bedaclin needs to be loaded over a 2-week period, and the adverse effects of note are hepatotoxicity, which many of us are used to in dealing with TB treatment, but adds a risk for QT prolongation, which, adding EKG monitoring as a new requirement has been a challenge for public health programs that work with TB. You could imagine the huge shift of moving away from injectable agents is really something that was happy news for TB survivors, TB activists around the world. Injectable agents on the widespread use, globally for TB for such prolonged periods really did cause a high degree of morbidity and disabilities. And this patient's comment about having to choose between death and deafness was all too common. So the good news is in the last few years, we've seen at least particularly in the US, a steep drop-off in reaching for the injectable agents as they're, part of our treatment of choice. And we've really embraced the addition of Bedaclin. And the California MDR service shared this data with me. They tend to carry the heaviest burden of MDR cases in the US. We don't have a lot of MDR in the US, but they have fully switched over, only using injectable agents when they have to, and often just as a bridging regimen while they're waiting for Bedaclin. So again, I'm just showing this again to you just to appreciate the kind of complexity of the drug combinations that are used, appreciate the risk for adverse events, because almost everyone gets sick with our medications. But with the highly individualized treatment choices that we make in our US practice, our outcomes tend to be pretty good, even though the duration is long and it's hard to tolerate. California's data from 2009 till now shows at least a 90% cure rate for our drug-resistant disease. But again, we really want to do better, and we need to, because of the effect it has on the lives that we're trying to help. So let me get to the Xenix trial. What about these 3 drugs, the ones on the right hand, compared to the standard of care for MDR treatment around the world? So this 3-drug regimen made up of Bedaclin, a new drug protomidate, and a higher dose of linezolid for 6 months. You can see how appealing it is if this actually worked. So published last year, the Xenix trial, TB trial, using this BPAL regimen was a phase 3 multi-center open label single arm study done in South Africa. It was assessing the safety and tolerability of this 3-drug regimen. It enrolled XDR and MDR intolerant or non-responsive cases with enrollment of 109 patients. So small study relatively. And I think it's important to note that this was a single arm study. There was no control arm because at the time of study design, survival for XDR in South Africa was less than 20%. There was no standard regimen available. And so everyone was enrolled into this 3-drug trial. Protomidate is a new drug for TB. Another hooray, because it's been so long since we've had new drugs. Those of you who know delamidate, which is not available in the US, it is related in structure to delamidate. It's shown in preclinical trials to have the quality of being able to both kill replicating organisms, so bactericidal effect, as well as non-replicating organisms, so that sterilizing effect. So really that 1-2 punch that we're looking for in a good drug for TB treatment. And the rationale for this 3-drug combination is that, well, basically they are 3 drugs that we don't expect, and we currently don't see much resistance in the global population. They each have a different mechanism of anti-TB activity, and that even though protomidate alone and even Bedaclin alone have pretty decent bactericidal activity, in animal models when they tested the 3-drug combination, that bactericidal activity was enhanced. The study design looked basically like this. It was a 6-month regimen with the option for a 3-month extension if cultures were still positive at month 4. It is a regimen given with food and importantly, 7 days a week under directly observed therapy. The primary endpoint was cure status at 6 months post-treatment, but they did do secondary analysis, watching and following these patients for up to 2 years after study completion. In terms of demographics, I just want to highlight that this was a pretty young study population with a median age of 35. It was pretty evenly split between males and females, and certainly the racial characteristics reflect the South African study site, and the median BMI was low. The other thing to really notice is this is a lot of XDR, right? The majority of cases were XDR. That means that they probably had a few rounds of treatment for MDR, for TB, leading up to this enrollment. Then there was a pretty even split between MDR non-responsive and MDR treatment intolerant. A little over half of this population was HIV positive. Now they were all on ARVs, and you see a mid-300 range with their CD4 count. But what else was really notable are these are people with extensive disease. You can see the vast majority had cavitary disease, which tells us they had a pretty high bacillary load, and a good percentage of them had bilateral cavitary disease. So the study outcomes were really impressive. The published primary outcomes showed at least a 90% relapse-free cure at 6 months, and the secondary outcomes shared in abstract form earlier this year just dropped down a little to 88% relapse-free cure at 2 years out post-treatment. You know, again, this is really remarkable compared to the less than 20% survival rate for this population in South Africa before this trial. Other important thing to note is that they converted their cultures pretty rapidly. A median time was 6 weeks. And these study authors concluded basically that the short, simple regimen was effective to cure a large majority of highly resistant TB cases. Now, the limitations, of course, it wasn't a randomized control group. It was done in a single country, and it's a relatively small study population. And we are still waiting for the full publication of the 24-month follow-up data. I think it's really worth taking a minute to talk about important dose modifications here. That was, linazolid dosing in particular was allowed to be modified during the trial. And that this study dose of 1,200 milligrams is a lot higher than we're used to using routinely in TB, particularly because we treat for such a long period of time. And I know a lot of you guys are infectious disease folks, and 1,200 milligrams is common for gram-positive infections, but you may use it up to a month in total. But certainly when we're going past a month, we're very concerned about the potential for adverse effects. And what was required in this trial was that everyone got at least the 1,200 milligrams for a full month. And I think pretty remarkably, 15% completed the full 6 months at 1,200 milligrams. But you can see a little less than half of them had to have their dose interrupted because of adverse effects, and either they were able to resume at the same dose or start at restart at a lower dose. And almost a third of them actually had to come completely off linazolid, and they finished the trial just on Bedaclin and pertominib. On the right-hand side, you can see the timing of the adverse effects. And what's notable is that the peripheral neuropathy primarily seemed to really hit its stride in the latter half of the 6-month treatment, while myelosuppression was actually an early side effect, often seen in the first couple of months. So 100% of people had some level of adverse effects. 17% of them serious, 57% grade 3 to 4. So those are pretty serious. Well, they're good size adverse effects as well. The vast majority had peripheral neuropathy, 81%, and that's mostly mild to moderate. And again, mostly came later in the later half of treatment. There were 2 cases of optic neuritis, and the good news is they resolved when linazolid was stopped. And almost half had some problem with myelosuppression, but they were able to usually manage it with just interrupting the dose, the linazolid dose, and maybe decreasing the dose. The majority of those cases were anemia, and again, that tended to happen early in the treatment. There were some cases with elevated liver function tests. Most were able to be managed with just holding the medications briefly and maybe restarting, and everyone with increased LFTs finished the 6-month course. And there were no problems with QT prolongation. And I think what most of us were truly reassured with the early release of data this year, that the 24-month follow-up showed that most of the cases in neuropathy resolved by 2 years out, but not all of them. So there were some 12% with mild to moderate, what appeared to be permanent symptoms, and at least 1% person with severe residual symptoms. So what happened after this, actually after the preliminary data was released, is that the FDA actually took an unusual move and rapidly approved Protominate in August 2019. But what was unusual here is they approved this new drug Protominate, but only as a part of this 3-drug regimen. And only for XDR or cases of MDR who are not responding to treatment or intolerant to our current drugs. Well, your friends here in Washington were early adopters. I think the first case that got started was supported by folks, our friends in Florida, but soon after, Dr. Narita, Dr. Dave Horn, Dr. Chris Spitters, who I think many of you may know, started actually a family of 3 and 1 additional patient, all who were pre-XDR on this new BPAL regimen. And so again, a little, but only slight deviation from the FDA indication. And what's notable here is that they were all non-cavitary, very low burden disease patients. And like the group in Florida, I think US providers were more hesitant to start the 1200 milligrams. And we have a practice of 600 milligrams linezolid for long durations of TB care, but using therapeutic drug monitoring to guide our treatment levels. And that was not an option for clinicians in the Xenix trial. And so using this strategy, all 3 of these patients were continued on 600 milligrams for the full 6 months, and then only 1 person actually had an increase to 900 milligrams. To date, they've all done well, temporary increase in LFTs, 3 with mild neuropathies, but so far no evidence of relapse. So those were the early cases. And the most recent case that I've been talking with the folks who started it is a case in Alaska. And you can see how people have gotten a little more comfortable with thinking about using this drug. This was a 25-year-old Alaska Native gentleman with pan-sensitive cavitary disease, so really extensive disease. He had failed 4-drug regimen at month 8. They were trying for a 9-month regimen here, and then he ended up with acquired MDR. Now, he lived in a very remote village in Alaska. He had multiple breaks in treatment. There wasn't a clinic in that village, so they used a family member to support his directly observed therapy. These kind of remote conditions make treatment completion really difficult, especially, he worked as a windmill repair on part of a team that did windmill repair, and there's also a lot of subsistence hunting that happens in Alaska, so people leave their villages for long periods of time. So the 6-month directly observed therapy during winter was really an attractive option for the TB control team in Alaska. And I think the team and the patient discussed this, the off-label use for just regular MDR. And so far, even with this extensive disease, he showed us, a good trend in going from a 4+ smear positive down to 1+ at 2 months in. And he's also using the 600 milligram strategy with checking drug levels. So that's basically what it's starting to look like here in terms of adoption of this regimen in the US. And you can see the California team, in the last couple of years, again, our numbers of MDR are unusually low, and we all think that it's, there was only 56 cases reported last year in the US, which is a drop from about kind of our average of 100. So we think it's reduced case finding during the pandemic, and it will come back to bite us later. But right now, even in 2021, probably 60% of the cases of MDR TB in the state of California are being started on BPAL, or what we're calling BPAL Plus if they add extra agents. And then with help from my friends at CDC and Florida, our very rough estimate is that there's probably 79 cases in the US where BPAL has been used. Most, of course, are MDR, often with intolerance to our MDR drugs. We only have about one case of XDR per year. There are a few extrapulmonary cases, and almost all of them have been started with the 600 milligram strategy and then checking drug levels. The Florida group, SNTC, said of their 49 cases, 26 have had doses adjusted based on the therapeutic drug levels, and most of them being adjusted to every other day dosing because of the high trough, with a couple needing increased doses up to 1200 milligrams. So far, nobody has stopped due to adverse effects, at least permanently stopped. They might have had holds, and there is no relapse to date, but of course, this is really still pretty early. So exciting early data, but small data. But in using this regimen so far, both patients and providers have found it really encouraging, and they're very accepting of this change. And I would want to really stress that this has been, relatively rapid pickup of off-label use of this new regimen, and it really needs to be done in a very patient-informed, open and transparent way. And most would suggest, consulting with your local TB experts to get going on it. So practical issues, what are people asking out in the field? And I can just say I just got off a 4-day conference of Pacific Island nations, and including our friends in Hawaii joined that group, and they presented a case, and they said, the bottom line, Lisa, is it's really hard for some of us to, get peaks and troughs. We're understaffed, we're under-resourced, we have to ship to far away. Do we need to do that? And are we okay with the 600 milligram dose alone? Can we just assume efficacy? The study used 1200 milligrams. What are we doing? Is there anything that can guide us? Well, I want to say the good news is this has been a bumper year for at least some early data. And the folks from the Xenix trial moved on to do what they call the Xenix trial, where they tried to optimize the linezolid dose. It is another phase 3 multi-center 4-country study. And they basically ran 4 parallel linezolid dosing arms using either 1200 milligrams or 600 milligrams for 6 months or 2 months duration. It was very similar in design to the Xenix trial in terms of the treatment parameters, but they did change the Bedaclin dose. And I just have to note that where they reduced the load and they went to a lower daily dose of Bedaclin, they had some PK modeling data that found this equivalent. And in the long run, this kind of daily dosing that you don't have to switch around 3 times a week will be easier globally, because they can hopefully build a fixed dose formulation for global application. But there were, XDR patients, 41%, they did enroll and identify cases as pre-XDR, and they had a smaller percentage of MDR. It was, again, a young population, mostly male, and 20% HIV positive. So the preliminary results shared this summer in the abstract form, and then again just this fall, showed basically this, that there was similar efficacy across all 4 arms, whether you use 1200 milligrams or 600 milligrams at 6 versus 2 months. But the 600 milligram per day arms of using the linezolid had fewer side effects or reasons for dose modification. You see the median time to culture conversion was still around 6 weeks in all of the arms, but a little bit slower in the arm that only used 600 for 2 months. That was also the arm that had the only treatment failure in this study, and relapses were pretty evenly spaced, except for there were none in the folks who had linezolid 1,200 milligrams for all 6 months. Here you can see the comparison of adverse effects between the 4 arms, and for sure the 600 milligram arm certainly did better. I think that for US providers who have been using this 600 milligrams as their primary strategy from the get-go, this is encouraging news. It appears to have a better safety profile and equivalent efficacy. But we really are waiting for more of this data from the Xenix trial to be published for us to look at it a little more closely, particularly what they did in terms of dose modification. So in general, we're learning a lot in terms of the safety of using linezolid for long-term in our TB cases. And this is what I think most folks are still advising, is that I think for the US, where we have drug levels available to us, most are doing troughs and peaks using evidence from Korea trial, trying to keep our troughs less than 2 to avert undue adverse effects. What's interesting is that authors from the Nix and Xenix trials also took some of their PK data. They had a subset with more extensive PK data and therapeutic drug levels. And they were looking for indicators that might predict risk of adverse effects. And what they saw was that actually one of the early signs is something easy for people to follow, is to look at hemoglobin level. If there was a 10% drop from baseline to 1 month out, it could predict cases of more severe anemia, and you can make an adjustment early and avoid that. And they also actually looked at the drug levels and the trough, and they weren't convinced that a trough less than 2 predicted neuropathy entirely. And they thought, at least from a practical standpoint globally, that following your neuropathy exam and evaluation, clinical evaluation, might be good enough. But we're still waiting to see more of that information. And that was a pre-publication by Marjorie Imperial and Radha Savik. In general, what have people been doing? We've used linezolid for a while in these longer regimens. And I can say that the California team has, they've published on this, and they have a long track record of good success. And what they've been doing, based on some earlier studies from Korea, is starting with 600 milligrams and then adjusting to 3 times a week dosing, or reduced 300 milligrams a day after culture conversion. But they aren't applying this to the shorter 6-month BPAL regimens, but just some tips as we go. Well, what's another practical question from the field is we're actually seeing people who are starting the BPAL regimen kind of hedging their bets and slipping it in as part of a 5-drug, the US guidelines 5-drug regimen at the start of care for drug-resistant TB. And people are asking, well, do we just keep those drugs on? What do we do? And I think, for most people, the Xenix and Xenix trials didn't have additional drugs. They had great outcomes. I don't know that we need to add these extra drugs on board, but I should say, again, new data out this year. The TB practical trial was stopped partway through because exciting positive outcomes. And this is a 3 parallel arm trial looking at slipping in moxifloxacin on top of BPAL, or clofazimine on top of BPAL, versus BPAL alone, all compared to the WHO standard long duration MDR care done globally. And they used kind of, what they called a pragmatic adaptive study design, looking at the preliminary 8-week kind of interim analysis data. Their data and advisory board did find that all 3 arms met criteria to continue in the study, but with this adaptive design, the study authors decided from a practical standpoint, they would only carry forward the moxifloxacin plus Bedaclin arm. It did have some early signal of advantage. And the bottom line is that partway through the trial, the Data Safety Monitoring Board indicated that they had reached criteria for stopping early, and that this BPA plus Moxi arm showed favorable outcomes of 89% compared to the standard of care, 52% in the modified intention to treat analysis. And you see that the per protocol analysis, certainly standard of care did better if you completed all of it, but still a notable difference between the study arm versus control. The main difference was driven by deaths and discontinuation of treatment in the WHO standard of care arm. There weren't relapse or failure noted in either arm, and there were notably fewer side effects in the BPA plus Moxi arm compared to control. So, is there a clear-cut advantage to moxifloxacin added to the BPA regimen? Not sure. I think we're all waiting to be able to see more of this data from the practical trial. So just, in summary, for this new exciting, BPA or maybe BPA plus regimens for drug-resistant TB, I think we all agree that the efficacy data is really exciting, and there's more data coming from a lot of sites who've started operational research trials. The strategies to reduce the linazolid related toxicities are very important here, and we're waiting for the full disclosure of the Xenix data. The FDA approval is only for XDR or treatment intolerant or non-responsive MDR, and I think we all have to remember to be, do that open counseling and transparent education to our patients as we make these decisions. And for those of you who work in a global setting, know that there's assistance out there with tools and workshops to get this started under operational research conditions. And I think the things that folks are struggling with every day is, when cases are coming up with different patterns of drug resistance, even, not just plain MDR, but just RIF intolerant cases. They're looking at very long durations of treatment, and people are wondering, can we just use BPA? And we'd say, turn to your friends, do TB work all the time, and we should talk about it. So, and the last part of this talk, is there something new for drug sensitive disease? Well, finally, yeah. So here, the TB Trials Consortium Study 31 published earlier this year. This was a randomized open label, non-inferiority trial run across 13 countries. And the key study question was, if we use a higher dose rifamycin, and in this case, the longer acting drug rifapentine, with or without the addition of moxifloxacin, can we shorten our standard 6-month treatment for TB down to 4 months? Here's the study design with a 1:1 randomization. The control arm is just our standard 4-drug regimen with INH, RIF, ethambutol, and PZA. The second arm substitutes rifampin with the longer acting rifapentine. Now, what we're doing is, we often look at rifampin as our, best all-around player in this 4-drug regimen because of its both bactericidal and sterilizing activity. And we know that from animal models that we are, just midway on that dose response curve, and that, we feel like there's more potential with the rifamycins if we boost the dose. And so here we're using rifapentine daily. The third arm swaps out both the rifapentine into the RIF slot, and then also swaps out ethambutol for Moxi and uses the Moxi for the full 4 months. Now, again, this is a 7-day-a-week regimen. You can find many public health programs dosing under directly observed therapy for only 5 days. There was 5 days of directly observed therapy, but they still did dose or have the patient take doses on their own on the weekend. This dose of 1,200 milligrams of rifapentine is much higher than what we're used to. A lot of us use rifapentine at 900 milligrams once a week for latent TB treatment. So 1,200 milligrams daily is a much higher rifamycin exposure. And the moxifloxacin dosing is standard 400 milligrams. And you need to give the rifapentine with food to enhance absorption. You can see there was a robust recruitment of over 2,500 patients into the study. Most of the patients, the vast majority, were from South and Eastern African countries. And you can see only 27 patients were from US programs. The populations across the study arms were pretty evenly matched. Notably, again, they were relatively young population with a mean age of 31 years old, majority male, 71%. Certainly the racial breakdown reflects the country enrollment. And I wanted to highlight that there was a modest 8% inclusion of folks with HIV disease as well. And again, like the Xenix studies, these are patients that had a pretty significant extent of disease, with 72% having cavitary disease. And they also all, the median BMI was low. And here's the primary efficacy results. Now, the study design here was a non-inferiority design with a margin set at 6.6%. In other words, to demonstrate non-inferiority, that upper bounds in the 95% confidence interval for the difference in proportion of unfavorable outcomes between the investigational and control regimens should be below 6.6%. And furthermore, that non-inferiority criteria had to be demonstrated in both the co-primary analysis populations of those people who were accessible and those who were microbiologically eligible. So the upper graph shows the rifapentine-moxi regimen. And you can see that for both co-primary analysis populations, that it met the non-inferiority criteria. But the lower graph shows you that for the rifapentine substitution alone, and that you can see those confidence intervals going over that 6.6% non-inferiority margin. So that did not meet non-inferiority criteria. If we look at the primary efficacy analysis, comparing the control, and I just highlighted the control on the rifapentine-moxi arms, you see that they were pretty comparable. They did well. You can also note that the absolute majority of cases had microbiologic confirmation of cure. 34 patients in total study population couldn't produce sputum at the end, but were felt to be clinically cured, but the vast majority actually had laboratory confirmation. So again, with early data release, people were excited. And in fact, the WHO released a rapid communication in June of this year, sharing the data, information from study 31, and basically said this could be a very strong patient and program preference. And they are, as we speak, updating their WHO guidelines for drug-sensitive TB. In their document, they also recognize that we need to have cost reduction and certainly increased availability if we were to have widespread uptake of this regimen. And we have to be very careful with our fluoroquinolone resistance surveillance. So it's important to look at the safety analyses here, noting that there was a slightly higher proportion of grade 3 to 5 adverse effects in the rifapentine-moxi arm, but it's also worth pointing out that the overall proportion of treatment discontinuation or tolerability, having at least one adverse effect, and the number of deaths were slightly lower in the arms using rifapentine. And if we look at the breakdown of adverse effects of true interest to us, leading to discontinuation, of out of the regimen, you can see that both rifapentine-containing regimens had a higher rate of hepatitis, and that there were at least 2 cases of study discontinuation due to the moxifloxacin, one with a prolonged QT and one patient with tendinitis. So, you know, what are we looking at here in terms of thinking about, are we going to take on this new 4-month regimen? So I know for, our US audience, we're a little concerned that our populations here are much older than those included in these studies. Our TB populations have a lot of comorbidities, a lot of polypharmacy. So we are a little more concerned about QT prolongation because often patients are on multiple drugs with that risk. Our older population is a greater risk for tendon rupture and hepatitis. We call on our consultants from different specialties often to help us through these cases. Globally, can we get moxifloxacin and rifapentine out to everyone? Now, in the US, we can get moxifloxacin, but you would be surprised how hard it is to keep a steady supply of rifapentine. And I think the market forces are going to take a while before that stabilizes. And then there's also the ability to get rapid and reliable fluoroquinolone resistance testing. That needs to be scaled up on a larger scale. And in fact, there are many US programs that can't get them as quickly as you wish you could. So practical unknowns, that are coming up every day. What would you do? How do you know when to extend treatment? Is there evidence for when someone would do better not being on 4 months and having to extend the regimen? Can you substitute levo for the moxi? We don't know. Can we use it in extrapulmonary disease? Not clear yet, but certainly I think that all of us and those of you who are often consulting on our cases with us in different specialties, we just need to watch, because I think the standards of TB practice are really evolving at this moment. And I think we're going to see changes coming. So that's it. And I'm sure if Dave Park was here, he'd say something tremendously witty right now to end this talk. But I'm just going to say that I really have great hope. And thank you so much. Thanks to all the people who gave me their data and supplied slides. And thanks to Masa and Dave and folks there in the Department of Medicine for inviting me. All right.
Thanks so much, Dr. Chen. We do have a question that came up. When you were talking about study 31, the question was, how about Telacebec? Not sure if I'm saying that right. Telacebec, it looks like it's a newer TB drug as well.
I will be the first to admit when I don't know something, and that is not a drug that I'm familiar with. And I'm going to turn to Masa and say, Masa, there are related drugs as well to linezolid that I think are in phase 2 trials at this point, and we're hoping to get them into phase 3 to see if they're safer. They certainly have a safer profile. But Masa, any words of wisdom there?
No, well, I'm not familiar with that particular drug.
Matthias, go ahead and tell us more. I don't know. Masa Narita, are you gonna start using the 4-month regimen?
Yeah, as
for your cases.
As your last highlighted, I will be very careful in our older population with the multiple comorbidities.
Yeah. I think globally, I have great hope. Dropping from 6 months to 4 months for programs where there's high rates of TB could really be a game changer. If they get the drugs available and if you get them the fluoroquinolone testing, because they have a younger population. It's San Francisco program has rolled out an early pilot program, and right off the bat, older patients, bad side effects, drugs held. But we're not going to stop. It's just that difficult learning curve, right? You've got to get it down. You've got to get it right. We tend to be a conservative bunch, and I'm just saying, go for it. Just do good medicine. You know how to handle this. And if someone looks like they're gonna fail if you stop early, extend the treatment. But don't be afraid. I think we need to break through. Has masking during COVID reduced TB transmission, or is it too early to tell? That is something we're all wondering. We've seen a huge, well, not everywhere, but for many programs, a drop off in detection of TB here in the US. And we think that it's just that everyone's been so busy with COVID, and they haven't wanted to come in with TB symptoms, that we've got low case detection, but we also are open to the fact that there are people who are masking and kind of transmission being another airborne disease, right? Transmission may go down. So I think you'll see different dynamics depending on the place and the setting, right? And we're certainly seeing a lot of people with delayed diagnosis of TB and actually dual diagnosis of COVID, and then eventually figuring out you also have TB. And across the board, I could say TB controllers in many different states keep telling me, Lisa, they're coming in more complicated because people have been waiting a long time, or they have COVID on top of it, and they're just coming in with sicker, more disseminated disease. Feels like a ton of, consults for TB meningitis and things that could have been caught early before it's just disseminated everywhere. I'm looking, any other questions? I'm really pleased so many people stuck around to listen to TB.
Maybe we'll just give it, oh, there's another question.
Also some data out of East Germany that TB vaccine prevented COVID, the T cell activation. Yeah, we'll see, right? We'll see. I think what's really going to be impressive is the breakthroughs in kind of treatment advances and vaccine advancements, and you just want to. We're hoping, TB needs to ride on the coattails of all this if we can. TB kills a lot of people, but they tend to be in areas of the world where there's not a lot of voices or political power, and the resources are low. A lot of people in the US think it's gone. It's kind of off their radar, and it's hard to realize that it's one of those things. If you don't keep public health healthy, and we're keeping a lid on it in the States, but the minute you dismantle our public health structure, boom, it comes back because it's everywhere. And so it's like COVID. If we don't take care of it everywhere, we're always going to be battling. Carpe diem. Go, Barbara. Yeah. What about kids with MDR and XDR? What treatments are we looking at? Hi, Carolyn. I think it's hopeful that they've even included adolescents into these trials. I think that's a big boost, but we need more data in younger kids. And for the most part, for sure, they tolerate these drugs much better than the older adults. So we're hopeful, but we really do need more TB trials in pediatric populations. And we need, we've been fighting for years for pediatric formulations, and we don't want to just crunch up adult pills for kids. And those are finally available globally, but we can't get a hold of those formulations here in the US. So it's a bit crazy. There are newer diagnostic tests that are easy to use in clinic sites, and extra rapid diagnostics using just GeneXpert for expanded drug resistance. And again, they're available on the global market, but companies don't see the US market as big enough to actually get FDA approval. So, Moss is wishing he had access. to some of those tests that I can get in Dar es Salaam.
Well, I think we've reached our time. Thank you so much, Dr. Chen, for this talk. And thank you to everyone for joining us today. Any last words, Dr. Narita?
Thank you so much, Lisa. We really appreciate you. And thank you so much, Nina, as well.
You're welcome.
See you in Seattle at some point. We'll get rid of the Zoom.
Take care. Thanks, everyone, for joining us.
Thank you. Bye.